Okay, I think the numbers are quickly going up, so I think we've got enough people to get started with today's session. Um, Thanks, Nicola. So today we're focusing on palliative care, specifically the three stages of palliative care integration, and Prof. Renee Krause will be our speaker. But just to start with a bit of background, as you know, Bloody Say brings deep dive to us. And we're thankful for all of the hard work behind the scenes in partnership with Sagas and Sassets. Our deep dive management team, Professor Estelle Verberg, Dr. Kadeen Kritzinger, and Dr. Nicholas Smith, are the team behind this amazing platform we get to share in, and thank you for that. So just a bit of housekeeping. The recordings are all the sessions are recorded and can be found on the bloodessay.org.za under resources, deep dive. And for the session, please feel free to add any questions or comments to the chat box as we go, and we'll respond to them at the end of the presentation. In terms of CPD points, they'll be submitted to HPCSA for each registered South African attendee. So please just make sure you're attending on your own registered Zoom link and not in a group. You have to attend for at least 1 hour and that your HPCSA number is entered correctly when you sign up for deep dive. Ethics CPD accreditation for this session is still pending. And then, of course, if you have any queries or need to request a CPD attendance certificate, please email admin@bloodessay.org.za. Please make sure you join the mailing list via the website under resources, subscribe to Deep Dive, or you can use this QR code. In terms of feedback, the Bloody Say and the speakers value your honest feedback, so please complete the anonymous feedback survey at the end of the Zoom meeting. A big reminder for the 17th annual Heme-Onc conference coming up from the 19th to 21st of September. It will be at Century City, promises to be exciting. It will be Hematology in Action, Bridging the Gap, and brought to you by Sagas. Also, an advert for HHT Horizons, which will be happening at Century City Conference Center in Cape Town on the 19th of September, brought to you by Cure HHT, which is collaboration for innovative care in South Africa. So our agenda today, we'll have the three stages of palliative care integration by Prof. Renee Krause. We will then have a Q&A and then a closing at the end. So, Prof. Renee Krause is a family physician with a PhD and master's degree in palliative care medicine. She has 20 years of clinical experience in palliative medicine and 10 years of training supervision and research at UCT. She currently serves as the head of division of the interdisciplinary palliative care and medicine in the Department of Family Medicine, Community and Emergency Care at the University of Cape Town. Prof. Krause is the convener of the postgraduate diploma in palliative care, in palliative medicine slash care. Really an excellent course, which I am actually a product of. So just going to pause and say, encourage you to join that if you ever get the opportunity to do so. Um, she works clinically at Groote Schuur Hospital, providing consultations in palliative care. At Groote Schuur, she collaborates with various disciplinary teams, conducting combined ward rounds and providing consultations in palliative care throughout the 900-bed hospital. She is a board member of the African Palliative Care Association and serves as the assistant editor of the Journal of Primary Healthcare and Family Medicine. Her research interests include strengthening and integrating palliative care practices across the continuum of care. And just an advert for next week. We will be focusing on anticoagulation in 2025, lessons from recent clinical study by John Eckelboom. Okay, thank you. I'm going to hand over to you, Prof. We're all waiting with bated breath.
Thank you, Gamo, and thank you for inviting me to this group of hematologists. I think it's really wonderful to see how palliative care is starting to really integrate into hematology care. I think it's very delayed. I think we should all work closely together. And I really want to say thank you to people like you and Professor Verberg, who's really at the forefront of integrating palliative care and hematology care. So thank you very much for that. So I'm going to start sharing my screen. Are you seeing the screen? No, I think I've shared the wrong one. Let me just share again. There we go. Can you see?
Yes, we've got it. It's not yet in presenter mode.
There we go. There we go. Okay. Thank you very much for everybody, as I said, who've invited me and for giving me this opportunity to talk about palliative care integration and a little bit about palliative care. And I'm going to link it to hematology as I go through the lecture. I firstly want to acknowledge that really my palliative care team in Groote Hospital. And I think because, as Gamus said, we work across the hospital. And when you work across the hospital, you need to have a attitude of dual curiosity, where you remain curious in everybody's discipline and you learn from everybody. And I think if you're integrating anything in any area, whether it's hematology care, it depends on that dual curiosity and mutual respect, really to work together to get the best for a patient. So today I'm going to talk about three things. But I thought before I go into stages or levels of integration, and this is really what I've learned from integrating palliative care at Groote Hospital, I thought we must just first stop and sort of just make sure we're all on the same page. Make sure we're on the same page a little bit about the principles of palliative care. So I'm going to start off with just reminding everybody, and I'm sure many of you know this, but I thought let's just take a pause and just remember again what is palliative care. So palliative care is an approach. It's a way of doing things. It's a mindset change. And I think I spoke to someone today and I said, that's the most difficult thing to train somebody in. It's a mindset change. And the mindset changes to quality of life. And the mindset also changes to recognize that we're not only looking after the patient, but we are looking after the family member as well. So those are the most important things about palliative care. And it's about patients with a life-threatening illness. And we're going to talk a little bit about this concept about life-threatening. What is life-threatening? And when you are doing that, how are you then doing it using a physical, psychosocial, and spiritual approach? And just to make sure everybody's clear that spiritual is not religious, but it's a way how we work with patients about meaning making and sometimes integrating with a higher power, how we integrate all of those concepts. So fundamentally, it's quality of life, it's biopsychosocial, spiritual, and it's of the patient and the family. This definition of palliative care continues. And one of the most difficult things as a healthcare provider is to recognize that death is a normal process. We're not trained like that. We see death as failure. We see we've let people down. But the reality is that death is a normal process, and accepting that and working that within your clinical sphere is sometimes very difficult. The other important thing about palliative care palliative care does not endorse euthanasia. And so we don't even, euthanasia is not a palliative care approach. And on the other side of the coin is we do not prescribe a lingering death for a patient, which is sometimes very difficult, and where you get that balance. And that balance is usually arrived after many years of clinical care. Also, another very important principle about palliative care is that it always requires a team approach. If you are working alone, and you are working with patients with life-threatening illnesses and you're trying to do this on your own, somewhere something's going to go wrong. Because you are working with such a complex thing, it's called a human being, and then you're expanding it to even more of a complex organism called a family, that nobody has the skills to manage all of those complexities within this organism. And it is about enhancing quality of life. I can't keep on saying that enough. When we're looking at integrating palliative care, we say palliative care should be integrated at the point where a life-threatening illness is diagnosed. As the curative becomes less important, the palliative care becomes more important. Palliative care includes end-of-life care, but it's not solely end-of-life care. It's so much more than end-of-life care. And then fundamentally, it continues after the death with what we call bereavement care. And bereavement care happens in very funny places. It's not now I'm going for bereavement care. And I'm sure many of you have had family members afterwards just coming in or wanting to speak to you after the death of a loved one, and how we are present with them when they are arriving. That is some of the most important skills of bereavement care as a healthcare worker, is the being and the listening and the supporting, not always fixing. In the South African context, and I just want to say one of my gripes in life is that when we are here, all busy here, and we see someone is moving towards the end of their life, we must really think if there are vulnerable populations. And in the South African context, during the HIV pandemic, one of the doings of palliative care in South Africa said, in bereavement care and we across the continuum of care, we always have to think if there are vulnerable individuals involved as well, and how we look after them very specifically. I can just tell you this week, we've had 2 patients who, as we say it in Groote Schuur, they signed the red ticket, not because they didn't want the treatment or anything, they were just looking after vulnerable populations. And if we don't take that into consideration into their care, we lose the patient and we might leave a child on the street. So whenever you're thinking of palliative care, please think of that. So when we're looking at the integration, and this is a model that's used within the cancer paradigm, and we call it a bow tie model. It shows an integrated approach where oncology and palliative care works together. And the radiotherapy, the chemotherapy, everything is done together to try and provide the best quality of life for patients. The bow tie model. And I think this is really a model that's very pertinent within the hematological setting, especially when you're working with hematological cancers, where you are trying very dangerous treatments, and how you are then holding the patient and their family during all of this. Just one of my favorite cartoonists. Someday we will all die, but on the other days we will not. And I think, to me, that is what palliative care is. How do we make that patient with a life-threatening illness, undergoing a lot of treatment at that moment, have the best quality of life? Then for me, the next, goodness, Hello?
Hi, we are still with you, but
Sorry, I don't know what
your
happened.
penis just disappeared. Yeah.
Yes. I, can you hear me?
S-
Can you hear me?
Yes, we can hear you. It's just the screen that's disappeared.
Okay, so I'll talk on. For me, the important aspect, and I showed this screen.
I think it's just some technical difficulties, but I'm sure she'll be back in a second.
Okay, I think we'll just hang tight for the technical issues.
Okay. I'm so sorry. I think the UCT system went down. I'm so sorry about that. Can you see the slides again?
Yes, we can see them and we can hear you.
Right. So I think what palliative care is really moving from an empathetic to a compassionate approach. Now, just to talk a little bit about sympathy. Sympathy is when we look at someone and we say, oh, I'm so sorry. Oh, shame, shame piece. While an empathetic approach is really when a doctor starts trying to understand the patient's feelings and what they're going through. While a palliative care approach is really when we are moving towards action. And palliative care is the empathetic approach that includes action that is evidence-based. And to me, to understand that it's not just hand-holding, it is so much more, and that it really requires knowledge about what the disease itself, but knowledge about this physical and psychosocial and spiritual journey this patient and family are going through. So those are some of the very basics about palliative care. And I want to continue now with talking about levels of palliative care integration, or stages or levels. And for me, very importantly, I was really thinking, where should I go? Should I go from the healthcare worker to the healthcare system? Or should I go from the healthcare system to the healthcare worker? And I thought I'm going to start off with looking at the healthcare system first. Where are we with palliative care integration, so that you get a feeling of what actually needs to happen. But this slide should not be a linear slide. It should actually be a circular slide, because very much what's happening in the healthcare system is determined what's happening with patients and society, but very much what's also happening within healthcare workers themselves. So what are we aiming to when we are integrating palliative care? We want to see improved quality of life of patients and families. very importantly, we want a sustainable healthcare system. We want an improved patient and doctor relationship. We want families and patients to be resilient when they are facing this biggest trauma that they will be facing in themselves. And we want this positive resilience within healthcare workers themselves when they are facing these extreme situations of patients dying. So let's look at the healthcare system and where we are. So we all know that we are striving towards universal health coverage. And if you want to provide universal health coverage for patients, we know we've got to try and have a preventative approach, a curative approach, a rehabilitative approach, and a palliative care approach. So it has to be integrated all together. And I think sometimes healthcare workers forget to put the last sentence there, which says we should not expose the user to financial hardship. We shouldn't expose the healthcare system to financial hardship. So this has to be a sustainable model that can provide all the care that's possible. Now, for many years, and I will be very clear that palliative care as part of universal health coverage was only really integrated into the principles of universal health coverage within the last 20 years. And that's led to this complete abyss to palliative care. And the Lancet, in the Lancet Commission speaks about an abyss. It is so bad. And that 80% of the patients who require palliative care are living in low middle income countries. And we know only a very few patients actually have access to palliative care. And as I go through this, I hope you will start asking why the whole time. Why is this happening? What is it that's preventing integration? And you can just see, and I just a little slide again about this massive need, and I can't see, but it is the low middle income countries, what the diseases are that require palliative care. And that's still, you can see the hemorrhagic fevers, you can see that the malignant neoplasms are increasing, and all of these patients are actually going to need palliative care. And I can tell you from what we're seeing in Groote Schuur Hospital, the majority of referrals are still within the cancer patients, but very importantly, the renal patients are increasing as cardiovascular disease is on the increase. So a huge amount of patients that require palliative care. So if you are going to integrate palliative care, you need to think to yourself that you are going to need these health level out our health aspects that need to be done. And very importantly, as Gamu said, is education. Unfortunately, in many of our undergraduate curriculums, still there's not enough palliative care integrated. I can be very blunt about it. It's not really integrated in the undergraduate nursing curriculum, which is very, very worrying. And in very of the health and rehab disciplines, palliative care is not yet integrated. The worst part that it's not integrated in for me is that social workers are not really trained in palliative care. We also need policy, and then we look at drug availability. And I'm very vocal about the fact that morphine must be available at all healthcare levels. So just to look at this in a little bit more detail, that morphine and simple morphine syrup must be available at primary healthcare clinics. And if you are working in a setting where morphine is not available, you really need to ask deep questions on why not. And just, I know many of you are working in a private setting where I still hear of so many people saying, well, I can't prescribe morphine in the private setting because the pharmacies are not mixing it. Now, that is really concerning. What is happening in the private setting that they are not making a very cheap excellent medication not available for private patients. Why? So those are really difficult questions that we've got to ask. And as hematologists, as leaders in the field, we all need to ask the same questions. And then, of course, implementation, and implementation is about doing the work. And for that, it requires manpower, it requires budget, and oh goodness, Gamo, I've lost you again.
Okay. We can still hear you. Let's see.
Right.
Do you want to
Well, I'm
try
going to keep on
transfer
talking,
again?
and I know I'm so sorry about this. This is the seems it's suddenly load shedding here.
Perhaps if
So
you'd like,
I'm going to.
Or
if you'd like to,
Nicola, can you control? Yeah.
perhaps turning your video off might make the connection a bit more stable. And then you're also welcome to mail the slides to me if you like, and I can share them from this side.
Yes, I'll do that quickly. There we go. Well, I'm going to keep on talking, and I'm so passionate about this topic, so I will keep on talking about that. What has happened globally is that there's been a few very important declarations and policies that have come out to ensure this abyss to palliative care is actually managed. And one of the most important documents that came out was in 2014, when the World Health Assembly did the declaration declaring that palliative care is fundamental along the continuum of care. And very importantly, during this declaration, the World Health Assembly made very pertinent recommendations on teaching and training, and stated that palliative care must be trained to all healthcare workers on basic level, and healthcare workers working commonly with patients with life-threatening illnesses do require intermediate level training, and then that there has to be specialized level training available as well. In 2017, the South African government did our first palliative care policy, and we were very grateful for that. But unfortunately, the policy was not linked to funding, which of course is sad. But in many settings, many people started making plans, and we are very grateful that in the Western Cape, plans have been made to start integrating palliative care. And by doing that, at the moment, currently, we have 19 palliative care nurses who work across across the Western Cape in palliative care. And it was so wonderful when we saw that. Thank you very much. Nicole, if you can just go a few, are you sharing?
No, not yet. It's just still downloading on my side.
Okay. That we have 19 palliative care nurses employed, and just the 1st of September, we have our first palliative care doctor that started now, not our first palliative care doctor, but a palliative care doctor starting at Tygerberg Hospital. So this is really wonderful, wonderful news. So if you carry on, thank you very much. Further down, further. Okay, at the little housey there. So in order to do this, and if you're trying to integrate palliative care somewhere, you going to have to think about all these aspects that need to be available. And very importantly, it's the provision of palliative care that is so integrative towards to making sure it actually happen. And when I say it happens, it has to actually demonstrate that you are delivering palliative care services. Next slide, please.
Try and see if you can click from your side. I've given you control.
Okay, on my side, Nicola?
Sorry, on Prof's side.
Mhm.
No, it doesn't want to give me.
Okay.
Okay, I think we need to go one back. Okay, there we go. So also when we're looking at the healthcare system, we have to start looking at costing. And we can really say that how do we show that palliative care is cost effective and actually is called what we call value-based care. Now, this study that was done at Victoria Hospital here in the Western Cape demonstrated that those patients received palliative care, their number of days in hospitals decreased, the cost per admission decreased, and more patients passed away at home. And that's really something that we want to work towards, to make sure patients always, and I won't say that is 100, they want to actually be in hospital. But in this study that was done in Malawi, people looked at the effect on families, the hidden costs of patients with life-threatening illnesses. And I think that is something that we actually forget about, the hidden costs to patients and families when they are having life-threatening illnesses. And it's especially about losing jobs, losing a main caregiver, traveling far distances to receive treatment, families staying overnight in hotels, etc., to be with their loved one. So when we are treating patient families, really, I want you to always think about what are the for receiving treatment. Okay, so the next level of integration is the community. Well, the next stage of integration is how do we make sure if the healthcare system is okay, shouldn't we think about how communities are actually taking up palliative care or a palliative care approach? And there are two types of communities here that we look at. Firstly, the professional community, and this is what we are doing now. We are talking to you as a professional community do that, and it is about, sorry, it's interdisciplinary conferences, what we are doing, summer schools, in communities, how do we actually make sure when we are working with other disciplinary communities, how do we make sure those palliative care standards and palliative care voice is actually heard within research? How do we look at outcomes for hematological patients? Are we only looking at survival, or are we including parameters like quality of life? Are we only looking at outcomes of the patient, or are we actually looking at outcomes of family members and how they cope afterwards? So these are important questions that as a palliative care approach, we want to ensure this is integrated. And very importantly, that this happens not only at tertiary level institutions, but at primary care and secondary level care systems. And how do we think about then that they are using a palliative care approach as patients are moving through the system? So we also have to look wider society, and that means that every man on the street. And I want to show you in the Western Cape what we have done to ensure that we have a palliative care voice within society, and so that we can start educating communities about what palliative care is. And we've got the butterfly stamp. Now, in the Western Cape, we use a butterfly stamp for patients who are identified or who have received palliative care. That helps them to travel through the system very easily. They don't have to wait long queues, and they have been identified as being palliative care. What it actually means is that a palliative care conversation has been had with this patient and their families. But what we have found when we are doing community engagement, and this is a photo of where we got community members here at UCT, and we did community education. Very much importantly, communities are hungry for this conversation. Communities want to be involved, and they are really battling in their own settings on ensuring that their loved ones want care. We are afraid to have these difficult conversations, but if we are not having these complex, difficult conversations with patients and their families, these people suffer on their own. So we need to make sure that they become part of the system. And we're looking at a concept called compassionate communities to look at how we can upskill ordinary community members to actually start talking about palliative care. And very importantly, when we're looking at community participation and community involvement, it's how we make sure we are providing a contextually relevant type of palliative care to the people we serve. So very importantly, whether you are working in the Eastern Cape or in the Northern Cape or whatever, how do your patients actually want to be cared for? Okay. So let's look a little bit about patient and family care. So going from the community to the patient and family care. And what many healthcare workers will ask, who needs palliative care? Now, many years we use the surprise question. I will not be surprised if my patient dies within a year, and I think this patient then requires palliative care. The problem with this question is what I see and what a young registrar sees is completely different. And also, very importantly, how this is then influenced by context, because we do know patients have different accesses to care and what is available for them. So globally, what happened is this was a global problem that people started creating these tools. And healthcare workers, they want specifics. And it was a supportive and palliative care indicator tool. And this tool looked at two aspects. And the first aspect is the general condition of the patient. So looking at, can we identify frailty in this patient? Things like dependent on health, on people for the past 6 months, significant loss of weight, all of these things very specific, indicating a patient who might be deteriorating. And then there was the more disease-specific indicators. Now, this indicator was from the UK, and from this we already saw that there were major gaps for the South African context. And we created with hematologists who were on this group, we created the South African SPIC tool. And very importantly, hematological diseases were now incorporated in the SPIC tool. And also the indicators for frailty were placed at the bottom, because very importantly, we want to make sure patients actually receive a diagnosis. As I said, an excuse for poor care. So we need to make sure we are following an integrated approach. People do get a diagnosis, and importantly, we can then hone into very specific conditions where the patients actually specifically need palliative care. Within the South African context, when we developed the spectral, hematological disease were included. Cancer definitely is there, but also infectious diseases and trauma that's of course very common in South Africa. And I think when working with healthcare workers and talking about this, the hematologists will hone into the hematological diseases and think, oh, it's only that. But the reality is a patient with, example, kidney failure who requires palliative care because of their kidney failure will now present with a cancer. And we have to always see the patient in their fullness to actually define whether they require a palliative care approach or not. Okay, so why should a patient receive palliative care? Now, the common thing is, oh, it improves quality of life. Yes, and we are providing better care for patients, etc. But I just want to say to you, what do we actually do with the patients? Why should we see them? Because we are doing assessment of the patients, an in-depth and impeccable assessment of that patient, looking at pain and symptom control, looking at that psychosocial and the spiritual care, looking at future care planning. And future care planning in our setting is very complex because you can't really do future care planning unless the patient and the family both understand the diagnosis and the prognosis. And it's within that prognostic discussion that we are many times losing patients and their families. It's complex discussions. It doesn't take one discussion. It sometimes takes more than one discussion. It's also not I've had the discussion and it's finished now. It's an iterative approach where you sometimes have to visit and come back. And because it's such an approach within Critical Care, we have a system where we have a WhatsApp number where patients can phone in. And then, of course, it's a bereavement care afterwards. So it's really making sure that patient is receiving more comprehensive care. So just to show you the kind of symptoms patients are receiving. And in our research in critical care has shown that pain still remains the main concern. And talking about pain, that's why I'm so adamant to make sure that we have to have access to simple morphine. And then it's the other thing that we forget about. It's the depression, it's the anxiety, and a complex symptom to manage is the fatigue. And sometimes it's the fatigue that is the most worrisome for the patients. I am just so tired, I can't do anything anymore. And that fatigue affects the patient in their whole being and the family as well. And if family members don't understand or have a deep understanding about why there's such a level of fatigue, it sometimes ends up in conflict. So this is just a study, which was a sentinel study in palliative care. And it demonstrated that patients who receive palliative care had less anxiety, they had better quality of life, and they actually lived longer. Now you ask me, why do patients who receive this kind of comprehensive care live longer? And I was very fortunate to actually be in a lecture where Dr. Temmel spoke about it. And she spoke about it is holding hope. Now, hope is a very complex thing to hold because hope is definitely not a good news story. Hope is firstly realistic, hope is achievable, and hope is not don't worry. So making sure there are milestones and realistic hope and quality of life for patients that actually assisted in them living a better quality of life and ultimately longer. So just a little bit of humor. Yes, early palliative care is better, like before 4:30 in the afternoon. Okay. So as a healthcare worker, what should a basic palliative care skills be if you are now going to integrate care? And it is about basic pain control, basic pain symptoms, and then it's about community, a team approach. So those are sort of the basic skills that all healthcare workers should have when they are working within a palliative care space. So I think I've spoken enough that we are always working with total pain. And I'm not going to talk a lot about pain control. I hope there's lectures on pain control. But very importantly, when you are doing palliative care, when you are prescribing pain medication, you always have to have this slide in front of you at your desk. It's the SHIP model. It's a very great model for basic understanding on how pain control works. And this SHIP model goes around that. Very importantly, the most important part is the assessment, the communication, and the team approach. The non-pharmacological method that becomes the stem and the master of the pain control, working with the hematologist, working with your health and rehab people, and then moving towards the medication. It doesn't start with the medication. And importantly, that nociceptive pain and neuropathic pain have two different ladders that we use. But that isn't just a touching on pain control. It is much wider than that. But I think what is more important than medication, and what also it states very clearly in that pain assessment, is how we communicate with families and patients. And if I always teach the students, this is the only slide you need to remember when you are communicating. You need to practice self-awareness. You need to listen more than you talk, and you need to ask before you tell. And the gap within healthcare workers are they talk too much instead of listening, instead of practicing the self-awareness of how I am actually present in that conversation and how I am reacting to what is being said in that meeting. So if I ask you one thing to do is for this week, always ask before you tell. And just the last point I'm talking about, and that's where it's not in everybody's skill set, but when a patient enters to the place where they want to start talking about death and dying, or asking the difficult questions like, am I going to die? It is very important not to close that door, but to ask the patient what they are worried about, to explore this concern, because it takes quite a lot for a patient to ask this big question, and just to be quiet and to ask more than to say, I don't know. Okay. Then the other important skill, as I said the whole time, palliative care is working with families. In our settings, you must remember that the family are going to be the main carers of that person. And we need to develop a relationship with families to bring them into the care. The families mustn't wait outside. They must become intimate as part of the team looking after that person. They become your social worker, your physio, your OT, your nurse, everything. And I'm sure many of you have actually looked after people, and you know what a strain it is on the families. Long term, if families are not held within this space, we do see a level of depression, complex bereavement, and actually other health care or health illnesses that show their faces. So please, people, encourage families to work with you in the space. And then, as I said, lastly, when you are working within palliative care, it is always a team. Never try and work with palliative care patients or patients receiving palliative care on your own. You cannot do this. You have to ask for help. You have to bring your team members around you. You've got to create your teams around you. Okay. So the last part I want to talk about, and I think I'm sort of leaning into this. We've spoken about patient and their suffering. We've spoken about families. But what about the health professional? And to me, this is one of the biggest gaps that has not happened, and we haven't spent enough time around this to enable palliative care integration. And this is probably the biggest barrier to palliative care integration, is me, the healthcare worker, and not spending enough time reflecting on how working with patients with life-threatening illnesses actually affect healthcare workers. One of the students said, I didn't want to go and spend any time with that patient. Absolutely wanted to avoid this patient. A registrar this week told me, and a strong registrar said, I saw the patient and I had to walk out because it triggered me. And I do think as healthcare workers, we really need to take a step back and reflect on how this is actually affecting us and the healthcare, and how, if it affects us, how then does it affect healthcare workers. So this is not palliative care. I just want to say, when you are with patients, it's not just about hand holding. That's why we are having an active care approach, positive, planned, and purposeful. So when you are with a palliative care patient in your setting, you need to know that it's very dynamic, it is very comprehensive, and very interlinked. It is definitely not just holding the patient's hand. It is about being there for them, but it has to be active care. So we have to think about the way things are done. And this is sometimes very much, we stand around patients' beds. We don't sit for that 5 minutes with the patient. And many of you will say, I don't have time for this. The reality is, if you don't spend that 5 minutes with that patient, you start getting in a circle of readmitting and admitting the patients and readmitting and admitting the patients. Unfortunately, most of us were trained into ensuring a curative approach, and death is still seen as a failure. So, and just one of a quote here, the reality is that many see still patients who are dying as a failure, and many do not want the patients who are dying in their wards. There is a feeling that there's nothing I can do for the patient, so the patient must get out of my ward. So we really need to start thinking about, no, hold on. How do I look after this patient actively now so that they can go home, but they go home with a care package? And if it doesn't happen, how do we actually recognize that this is causing moral distress within healthcare workers? As I said, we need to ensure that we train healthcare workers who have the positive resilience to stay in that room when a patient is this sick. And I think there are many assumptions. And I think one of the biggest assumptions are that people think that they are trained. And there's a difference between working with dying patients versus being palliative care trained. Huge difference. So even though you are working with dying patients, it doesn't mean you're providing that active care to patients. How do we challenge these assumptions then? It's about active integration. It's about making sure you are talking to people, we are on the same floor, we manage that dual curiosity when we are working with patients. And ultimately, have a non-judgmental, positive regard for all. Finally, and some practical skills, and I think it comes down to the bow tie model again. It's an iterative approach. We need to develop a contextually relevant palliative care approach for our patients that is contextually relevant for our setting. And we are only going to get this right if we talk to each other, if we talk again and again to each other, and ultimately provide better care for our patients. Thank you. And I'm so sorry about going up and down with the slides. I'm so sorry about that.
Thank you so much. That was fantastic. I am glad that your slides came to the party, but even without the slides, this was really fantastic. I'm a big fan, so let me go across to the chat box and let's see. People, please, I'm sure you have questions or comments. Um, we have Moses Chatambudza. He says, do we have local data on the frequency of morphine-related adverse events in the palliative care setting? That's one question. Then he asks, are we also making sure that naloxone is equally widely available?
Okay, thank you. That's an excellent question. So we don't have data on side effects. We do have data on the lack of morphine being used in the setting. And I think the problem is people are not educated on how to work with morphine. Firstly, morphine syrup is our way of doing things. It is very much advocated across the world. And I want to say in Africa, as I said, I'm part of the APCA board, and by the European Association of Palliative Care. We've had multiple European speakers and oncologists visiting South Africa, and the first question they ask, are you using morphine syrup? Yes, we are using morphine syrup. If you are using morphine syrup, the most important thing is start low and go slow. And very few patients will stop breathing if you start low and go slow. The problem is IV morphine in patients who are opioid naive and who have lots of other drugs on them. But no, the most common side effect of morphine is not respiratory depression. It is, Gamu, you should scream it out. Constipation.
Constipation is the big one. You must always have that bowel prep attached to your script for morphine. Yeah.
So I think this fear of morphine needs to be addressed, and that we really need to teach people how to start low, go slow, increase it, and how to even work with morphine when we are dealing with a population that perhaps have had previous addiction. We know these patients who've had addiction previously have many cancers. So we do need to have an approach to manage those patients as well. Thank you.
Actually, on that note, I'm going to ask a follow-up question about the morphine. I've often encountered patients who, once you bring up the use of morphine, some may receive it with some fear about addiction, some may receive it with some fear about dying. Do you have any advice about how to approach that conversation about actually, recognizing that there's a lot of pain here, you've needing to actually bring morphine as part of their treatment?
So what my advice is that I start off with saying, I'm worried about your pain, and I think we need to use morphine. And then I keep quiet.
So how was the swimming then? Did you get worse?
Sorry. And then I keep quiet. And what I do is I watch the reaction to the word morphine. And I ask people, even before they offer fears, I ask them, what are you worried about morphine? What have you heard about morphine? So you have to actually approach that very upfront with them. There are lots of misconceptions about morphine. The big misconception is it's going to make me die and I'm going to get addicted to it. So the question, it won't make you die quicker, people. Morphine's not the thing. But have you had the conversation actually about what's happening and what is causing the pain? The addiction conversation, you will become dependent on the morphine, but addiction is something else. It's a psychological feel for need for the drug, and that it's very complex to say to a patient in this stage. It's more important to actually concentrate on the pain control. The conversation needs to go to, is the pain taking away your quality of life? And it usually is. I can't sleep at night. And that is just tremendous. You know, once that pain is controlled, the patients are feeling so much better. Yeah.
Mm-hmm. Thank you.
So just the last point on that, I just want to say to you, it's not many times it's the patient who's got the fear, it's the family members who've got the fear, or it's the neighbors or the taxi driver. You know, they say, oh, you're on morphine. Woo.
Definitely, definitely. I've seen that as well. It's all, then everybody's giving advice about this morphine.
Yes.
I'm going to swing back to the chat group. A comment from Prof. Low. Excellent, wonderful talk, Renee. And then Garrett Lawden, for those of us who are interested in learning more about palliative care and its principles outside of a diploma, do you have any recommendations or suggestions? And then he adds, thank you, a wonderful talk and a great topic.
Okay, so yes, UCT's got a short talk on a short course on palliative care. So we've got an online short course, 48 hours. You can do the short course on palliative care. But you know, all registrars, I'm not say all registrars, hematology registrars are doing our course with the oncology registrars. That works well. But I can say very proudly that we now have a MPhil subspeciality in palliative medicine. So that is also, if you want to become a subspecialist in palliative medicine. But I think for someone who's just wanting to start about understanding what palliative care is about, the short course is definitely a way to go. If you are a Western Cape employee, then you can do it for free. And it is then through the Department of Health, Western Cape. If you are across the country, you can link with any, I think Gauteng has got a short course, and the Association of Palliative Care Centers have a short course. There are multiple short courses to do. I have to also say, if you need a little bit of bedside reading, I would really recommend Safari Journeys of End of Life Care. It's by a local African palliative care provider in Rwanda who speaks about family meetings. It's very good reading and making you understand how to work with families in our setting. Very, very, very good.
Thank you. Thank you. Made a little note there. Sounds like a good bedtime reading. And then more, thank you, Rihanna, saying very informative talk. Thank you. Then Nicola asks, comments, such a great talk, accepting that, accepting that in the right context. Right. Accepting that in the right context, death is not failure is a very helpful perspective. Are there any talks, books, resources on this topic in more depth that you could recommend? I suppose
So,
she's speaking specifically about death and that it's not a
yeah.
failure.
So, I mean, there's a very good book that was written by Peter Fox. I think it's still available on hospice care and caring for patients. A very good thing sometimes to give patients and families who are dying. And this is really in the active part of dying, which is a complex read, but it's a PDF. It is Crossing the Creek. You can just download it from the internet, especially when you are witnessing some of the signs of not eating, a bit of confusion, etc. Very nice read. It's a little bit thick, but you must just test your family if they're okay to read it. So first you read it and see how you feel about it. This Crossing the Creek, we actually gave to the community here in Cape Town to read. And some of them loved it and some said, no, it's too much for me. So just don't give it to everybody, just read the room. Yes.
Mm.
And then, of course, yeah, there's lots of books. If you also want a cheap read, just to read Tolstoy, The Death of Ivan Ilyich, that's just also very good.
Mm. Oh, fantastic. Thank you for those recommendations. Then Nanette Pina says, thank you. This talk helps me. My late sister required hospice admission and she was well treated. Mm.
Thank you.
Um, and then Garrick Lodden is back. He's really enjoyed this talk. Any recommendations for books, including novels, etc., that you've read that have changed your perspectives over the years?
You know what? And I think we're talking about books and people who read it. I think sometimes really changed my perspective on palliative care is just listening to the stories of the patients.
Mm.
Patients
Mm.
have wonderful stories. And I think if you just take a 5 minutes, it doesn't take long just to hear their stories and what they actually want. I think that's the best novel. South Africans and any Africans, and we've got great stories to tell. And if you listen to them, I think you don't need to watch any Seven Alarm or any Igoli ever in your life.
Just listen.
Just listen. Yes.
Ah. And that's actually quite interesting because one of the questions I was going to ask you was, how to gauge when patients are ready to discuss palliative care as a concept. I've always tried to bring in the idea of palliative care from the time of diagnosis, right? Obviously, trying to gauge what the family and the patient are like, especially when you know that what you've got is likely to go downhill sooner rather than later. So I think that's probably a skill that one needs to gauge because sometimes, you bring it up and people are like, no, 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 we're quite fine. We've got a great support network. But what comes out is a lot of anger through the journey. And then it becomes a bit challenging to try and you're trying to pull them in to be like, you need to start, having more of a conversation about what's happening to you, and they're pushing back quite a bit. Do you have any advice for that kind of scenario?
So the research shows, and I want to say this is a very much a evidence-based approach. We mustn't think it's just a talk here.
Mm.
Is that when patients are facing a life, and we all will, by the way, doctors are the worst, and healthcare workers are the worst, or we were all within a pendulum, and you've got to see it within a pendulum. People are hoping and worrying, and hoping and worrying. And as a healthcare worker, or we can't keep them in the hoping or on the hoping. We always don't worry, muni worry, we're giving you this drug, everything's going to be okay. Or we can't also keep them in the worry paradigm either. So we've got to help them swing between the two. And you all know some days the patient just wants to talk about my next visit to Mauritius, and the next day the patient is down. So you need to be able to swing in both directions. So the skill is to talk about, I'm so happy that you think God is going to cure you. I see your faith is very big. And I am worried. It's never a but. It's always an and. So you don't want to sort of be, you're talking nonsense. It's an and word. And I'm worried. And you use the word I'm worried. And I'm worried about other things. May I speak to you about my worries? Okay.
Mm.
So then you can go, I'm worried that you haven't spoken to your wife. I'm worried that you are in a lot of pain and you do not want to take your morphine. So it's your worry. If you want to explore the patient's deeper worries further, you talk about, and as I said in that communication thing, it's about asking before you're telling. I see you are very angry today. Do you want to talk to me about your worries and your anger? So I'm exploring, I'm not telling.
Mm. Thank you. That's very helpful. Um, Moses is back with a comment. He says, my patients who dislike morphine the most are actually healthcare workers, especially nurses. Usually difficult to convince them. Then Jennifer Corrin,
So it's
exactly.
who teaches you about morphine and the fears of morphine. Many times it's I'm sorry, I hope there's not anesthetists involved in this room, but it's the anesthetists who use IV morphine. And it is a conversation that you have to have with the nurses. You do need to educate them. And it's whatever nurses want to do. As I said to you, it's positive, um, that positive affirmation of each other, the dual curiosity. They want to do good. They don't want to be seen that they are hastening death. So you need to sit with them and show them what it does, how it works, how to omit morphine when they think it's too much, how to give an extra little bit if they think it's not enough. So it is about educating the nurses about morphine. And I can tell you, it's taken many years to get where we are now, that the nurses will hear says, yo, doctor, you haven't prescribed enough morphine for that one. Oh, no, doctor, where's the breakthrough dose here? It's taken many years to get there, but ultimately we can get there, but it is about education and and prescribing the morphine correctly. Morphine has got side effects, but if you do it correctly, and I think it starts with talking to your matrons and educating them.
Right, we've got Jennifer Coronhall. In terms of morphine use, she has an anecdote for us. Had a patient with severe pain who was using 350 milligrams a day to control the pain. We had to do a repeat valvectomy. She only needed about 15 milligrams after the repeat surgery. And she says, excellent talk. Thank you so much.
Yeah, so exactly. So you can, and I know of a patient who had a massive breast cancer and who had a toilet mastectomy. And after the toilet mastectomy, we could get the patient completely off the morphine quite easily. It wasn't an issue. But again, it's that, while you need the morphine, you need the morphine. Yeah.
Okay, Cynthia's just asking for the book title again. So for everybody, Nicholas put it into the chat box, Safari Journeys of End of Life Care and Crossing the Creek by Peter Fox, as well as The Death of Ivan Ilyich. Matlodi Molosi says, thank you for a great talk, very informative. Natasha von Meyer says, synopsis. Chicken soup for the soul at work. Stories of courage, compassion, and creativity in the workplace. It's like homemade chicken soup that warms the chill and heals the ill. This collection of 101 stories okay, it's a long is based on the belief that true testimonies of goodness and loving transformations can nourish us to the bone and heal the cynicism in our hearts. I see you nodding. It sounds familiar to you then. Um,
Yes.
Indeed, nearly every story seeps in deep. It's hard not to shed a tear of gratitude, feeling thrilled to have been touched and soothed so easily. Some of the authors are famous, such as Dan Millman, who writes an exquisite vignette on courage, and Gloria Steinem, who writes of the Royal Knights of Harlem. Many, however, have a short, simple story to tell about an event, a person, an everyday miracle that exemplifies the best of the human spirit.
And if you start following a palliative care approach, I promise you, you will learn that you can't do medicine anywhere else. You become really, it just makes sure that warming the heart. Yes.
I must say, I definitely try to incorporate a palliative care approach in my everyday practice. But one trap I find I've often been caught in, and I only realize I'm caught in the trap when we're really, truly at the end of life, is the over investigating, over intervening, and, sort of finding that line between there is still something that your intervention is going to change in terms of quality of life, versus, oh no, it's done nothing except just be something else that the patient must now endure, you know? Um, so I think that speaks again to what you were saying about listen, actually, and over time and with experience, start to be able to better gauge that point between where that toilet mastectomy, for example, is going to relieve pain versus actually it's not going to do anything at this point. We should just focus on as much as possible anything else for quality of care.
I think it's a very complex place to be in, and I do think, as you said, it comes with time. But one of the things that really took me years to, and as a doctor, and I'm telling you, is to figure out that death is not a physical thing. Death is a
Mm.
psychosocial, spiritual thing more than it's a physical thing. And the to make sure you are doing that thinking before you're doing the physical thinking. You really need to think that thinking through and making sure you've contained that aspect before you start containing the physical aspect. Just this week, just as a story, we were on a ward round in oncology, and the patient was on massive amounts of steroids. And we were really sort of thinking, what are we doing here with all these steroids? And really thinking to yourself, how am I holding? Am I holding a dying process that's going to just linger on? Or what am I holding here? But I think for me, the big thing is that shift you need to make is to realize I'm holding a psychosocial or spiritual event more than I'm holding a physical event. And that requires a listening ear.
Mm.
Okay.
Thank you for that. Thank you. So Garrick Loudon says, When Breath Becomes Air is another book that is lovely to read. Oh, this one I've read. It's, yeah, very impactful. And Cecile de Toy says, great talk. Training junior doctors about pain control is so important. I know a patient who had good pain control on morphine in hospital, but was not provided with morphine for a weekend pass. Oof.
I
Yeah.
think it's very important to realize that morphine should be available at primary healthcare settings. And in your hospital, if you don't have access to morphine, you need to be that advocate. You need to be that person that goes to the pharmacist and asks, why not? Because it's not, there should be no excuse to say, oh, we don't stock morphine. If the scheme says we don't stock morphine, you need to ask, why not? Because pain control is a human right. And one of the rapporteurs for torture in the World Health Organization saying that withholding pain control, proper, affordable pain control for patients is like torturing a patient. And that is a reality. And many of the drugs that are prescribed are sometimes too expensive for patients to contain. They can't afford those expensive drugs. Then they don't take them as often, and they take them only at night so that they can have a good night's sleep. So please be those advocates, because it's only if we start advocating as a community that we will really make impactful change.
Mm. Mm. No,
Okay.
thank you so much. And on that bombshell, it looks like we've had many people commenting, obviously, in the chat box. Um, and it looks as though the rest are stunned. So thank you so,
Again,
so much. This was an excellent, excellent talk and wonderful to get to speak with you. Thoroughly, thoroughly enjoyed it. Thank you very much.
pleasure. And again, I'm so sorry about the slides. I'm really sorry.
No, it was
Sharing.
excellent.
Thank you. Okay.
Thank you so much. And good evening, everybody.